Welcome to The Explainer. Today, we're jumping right into a highly anticipated 2025 paper from the journal Radiotherapy and Oncology, all about brachial plexopathy and head and neck reirradiation. Now, if you're a radiation oncology resident in training, you know that managing late toxicities is going to be a massive part of your future practice. So this study is a really big deal. It gives us some of the most concrete data we have to date on exactly how much radiation the brachial plexus can actually take before we cause irreversible damage during a second course of treatment. Okay, let's dive into the core issue. This is the daily dilemma you're going to face, sitting right there at the contouring station. You've got a patient with a locoregional recurrence, or maybe a second primary tumor in the head and neck, and you are basically walking a tightrope. On one hand, you absolutely need tumor control. On the other, you're terrified of causing devastating neurotoxicity. How do you safely deliver those curative doses when the surrounding anatomy has already taken a massive hit from a previous radiation course years ago? It's tough. Here is our roadmap for today's explainer. We'll quickly frame the re-radiation dilemma, then analyze the patient cohort, identify the specific risk factors, lock in your new dosimetric constraints, and finally, take a look at the future of toxicity prediction. Starting off with Section 1, the re-irradiation dilemma, where we're balancing tumor control with neural toxicity. We all know re-irradiating high-risk recurrences is vital, but the morbidity, well, it can be really daunting. Specifically, we're talking about RIBP, or radiation-induced brachial plexopathy. This is a severely debilitating side effect. We're talking about direct harm to the nerve fibers themselves or to the tiny blood vessels supplying them, which eventually leads to ischemia. For your patient, this presents as new onset pain, progressive weakness, numbness, or paresthesia in their shoulder or arm. It's life-altering and drastically drops their quality of life. And here is the absolute vital takeaway number 2 to keep in mind, 23%. That was the crude incidence rate of RIBP found in this study. Let that sink in. That is almost 1 in 4 patients experiencing this complication after conventionally fractionated reirradiation. And it's important to note nearly all of these cases were grade 2, meaning these are moderate symptoms that genuinely limit a patient's instrumental activities of daily living. Moving right along to Section 2, analyzing the patient cohort. This is a retrospective look at 48 patients. So who are we looking at? This was a retrospective review of 48 patients treated between 2015 and 2022 at a single comprehensive cancer center. Because some of these folks had bilateral neck radiation, the authors actually got to analyze 72 distinct brachial plexi that received overlapping radiation courses. The median time between the first and second courses, about 34 months. To figure out the cumulative doses, researchers fused the CT simulations from both radiation courses using rigid image registration, or RIR. Now, what's absolutely crucial for you to remember when you're in follow-up clinic is the timeline. The data over time shows that the median onset of RABP was 9.5 months post-reirradiation. The incidence hit 11% at 12 months and crept all the way up to 16% at the 2-year mark. The takeaway here? This isn't something that happens overnight. It is a slow, progressive deterioration of the nerves and blood vessels. That brings us to Section 3, identifying RIBP risk factors. What is actually driving this toxicity? So why did some patients develop plexopathy while others were totally fine? Well, first off, systemic therapy matters immensely. The data showed that using concurrent cisplatin during the second course of radiation drove a massive 60% incidence of RIBP at 24 months. Compare that to just 10% for patients who didn't get it. It turns out the neurotoxic properties of cisplatin, combined with high-dose overlapping radiation, basically creates a perfect storm for nerve damage. The other major predictor, and this is exactly where your contouring and planning skills come in, is cumulative dose. The researchers looked at the biologically equivalent dose in 2 gray fractions, or EQD2. An EQD2 maximum point dose of 103 GY2 or higher to the brachial plexus resulted in a 28% RIBP rate. But if they managed to keep it below that 103 GY2 threshold, the rate dropped dramatically, all the way down to just 3%. The contrast in the data is incredibly stark. Both the use of concurrent cisplatin and hitting that 103 G2 cumulative threshold remains statistically significant, even on multivariable analysis. Get this, the hazard ratio for the Dmax threshold was over 14, and for cisplatin it was almost 11. That's huge. And interestingly enough, none of the other clinical variables like age, smoking history, or diabetes were significantly associated with RIBP in this specific group. Now, while 103JY2 is the recommended cutoff derived from ROC analysis, meaning it gives you the best balance of sensitivity and specificity, it's worth noting that the data shows most of the actual RIBP events clustered heavily at or above 118JY2. But the authors still recommend 103JY2 as your constraint. Why? Because it provides the lowest dose cutoff associated with high sensitivity, basically giving you a much-needed safe buffer. All right, let's get practical. Section 4, Proposed Dosimetric Constraints. These are the actionable limits for your contouring. How do we actually apply this to plan evaluation today? Well, as residents, it isn't just about the maximum point dose. The volume of the organ at risk receiving high doses is absolutely critical. The data clearly shows that the incidence of RIBP was significantly higher for a V80, that's the volume receiving 80 gray, of greater than 1.94 cubic centimeters. The same goes for a V100 of greater than 1.35 cubic centimeters. Similarly, a V120, meaning the volume taking a massive 120 gray cumulatively of greater than 0.89 cubic centimeters, spiked the risk of plexopathy all the way up to 56%. Oh, and a quick anatomical pro tip from the study, the C5 nerve root distal segment was the most frequent location of the Dmax, so definitely pay special attention to that specific area when you're reviewing your dose volume histograms. So if you take nothing else away, remember this cheat sheet. When you're trying to balance covering those target volumes for recurrent cancer with overlapping courses, these are the exact constraints proposed by the authors to mitigate your patient's risk. Cumulative EQD2 Dmax less than 103. A V80 of less than 1.94 cc, a V100 below 1.35 cc, and keep that V120 strictly under 0.89 cc. You'll want to write these down honestly, because we really haven't had universally accepted constraints for reirradiation until studies exactly like this one.
But as evidence-based practitioners, you've always got to keep the data's limitations in mind. This was a retrospective study, right? Plus, using rigid image registration simply cannot fully account for anatomical changes, weight loss, or tumor shrinkage between the first and second radiation courses. Add to that, we still don't totally understand how much neural tissue actually recovers over the years between treatments. So treat these constraints as really strong guidelines, rather than absolute, unbreakable biological laws.
Finally, Section 5, the future of toxicity prediction. How are we evolving past these static constraints?
The future of predicting and preventing RIPB is inevitably tied to AI and radiomics. Instead of just relying on standard dose volume histograms, researchers are starting to extract high-dimensional, quantitative features directly from the medical images themselves. By leveraging machine learning, we're hoping to identify subtle imaging biomarkers that flag tissue damage way before the patient ever even reports a symptom. We're talking about moving toward truly personalized, dynamic dose constraints. Which leaves us with this final thought. As these AI models get sharper, and as we get better at mapping functional anatomy and prior damage, will radiomics completely redefine the way we set constraints in the near future? Are we about to move away from universal population constraints toward highly specific, patient-by-patient neural tolerance thresholds? It is a fascinating frontier, and it's one your generation of radiation oncologists is going to have to explore. Thanks so much for joining me on this explainer, and I will see you next time.